Okay, and I have gone ahead and shared my screen. Can you all see it? All right, I see a thumbs up. I'm going to go ahead and get us started. So today we're going to talk a little bit about CPCQC. My colleague Lauren is going to share some data about perinatal mental health and substance use complications in Colorado. Again, we'll talk about the Impact BH program and then the expansion process, which is why you all are here together with us today. So a little bit about us at CPCQC. Just as a reminder, for those of you who aren't familiar with us, CPCQC is considered Colorado's Perinatal Quality Collaborative, a PQC. Every state, or just about every state these days, has a PQC, and PQCs exist to address the leading causes of infant and maternal mortality and morbidity within their own state. Every PQC looks a little bit different. Some PQCs are part of their state, say Department of Public Health and Environment. That's what it looks like over in Utah. Other states, their PQC is part of their leading academic or research institution. So imagine if it were attached to Anschutz, that's what it looks like, I believe, in Vermont, in Virginia. But here in Colorado, our PQC is a nonprofit. And so while we work very closely with state partners, we are actually a nonprofit. And we really work across the perinatal landscape. To work together with the Hospital Association. We actually work with every single hospital with a labor and delivery unit here in Colorado, state partners, community-based partners, to collectively look at the data around what is causing infant and maternal morbidity and mortality within our state. And then we implement programs to address the leading causes within the state of Colorado. And a little bit about our team. My name is Kylie Hipschman, she, her pronouns, and I'm the Director of Integrated Behavioral Health here at CPCQC. I lead our perinatal mental health and behavioral health efforts, primarily our work that is focused on supporting communities. This is work that is particularly meaningful to me. I am a mental health clinician myself, and the bulk of my clinical career has focused on prenatal and postpartum mental health service delivery in the community-based setting. I'm also joined here with my colleague, Lauren. Lauren, do you want to introduce yourself?
Yes, hi everyone. My name is Lauren Smith. I am the Integrated Care Program Manager for CPCQC, and I really help to manage the Impact BH program. So for our partners, I'm typically the main point of contact and really pull together meeting spaces for folks to convene. And then I also and the person who typically receives and compiles reporting, invoicing, those types of things. And I bring a lot of things to this work. I'm very passionate about community birth and systems change and really working with community. Some of my work also looks like supporting our lived experience integration work here on the team. Yeah, I'll pass it to Casey.
Hi, everyone. So great to meet you. I'm Casey Canright. I'm CPCQC's Grants and Compliance Manager. I'm who you call when you have questions about your budget, if it's an allowable expense, and keeping the virtual doors open over here at CPCQC.
Thanks, Lauren and Casey. And then a little bit more about CPCQC. So we like to say that all of our work most often falls into three different buckets if you think about what we do. So much of our work is focused on giving infants and families a strong start, right? We know that the dyad begins in utero, right? And the more support that we can provide to mom or a birthing person during pregnancy and postpartum, the better off and more well supported that family and dyad are as they continue on into infancy, early childhood, and beyond. That means we do, some of our programs do intersect with dyadic care, specifically looking at supporting substance exposed newborns, working in the NICU setting, and we do have a new safe sleep initiative that works with hospitals on providing culturally informed and community-based as well as evidence-based practices related to infant safe sleep. All of our work is really focusing on pregnancy, preventing pregnancy-related deaths and complications. So that means we're working on maternal suicide prevention, unintentional overdose prevention, working on preventing obstetric complications, as well as increasingly focusing on intimate partner violence work. And then we also know that this preventative-based care, it actually reduces healthcare costs, which is something that we pay attention to through our work. And then I also want to note, for those of you who may have heard of CPCQC, a lot of times it's because of our hospital quality improvement work. Across the US, a lot of times this is the bread and butter, the bread and butter of PQCs. And PQCs are primarily known for implementing hospital-based quality improvement programs. These quality improvement programs are primarily from the Alliance for Innovation on Maternal Health. You may or may not have heard of AIM, and they actually have these evidence-based, nationally recognized bundles of very specific programs on addressing maternal mortality and morbidity risk within the hospital L&D setting. For example, a bundle of best practices on preventing and responding to postpartum hemorrhage or hypertensive disorders. But what we know, and this is what brings us to our conversation today, we know that we are actually not only at risk for obstetric complications, we are also at risk for maternal mental health as well as maternal substance use complications. And so something to know about CPCQC, we actually now work with 100% of Colorado's L&Ds on implementing these patient safety bundles, these hospital quality improvement programs. The logos for these different programs are listed right here on the website. We've got Turn the Tide, which is focused on perinatal substance use response, Spark, which is focused on safe postpartum discharge, including identification of maternal suicidal ideation, as well as intimate partner violence. We have SOAR, which works on safely reducing cesarean sections, and then NEST, which is focused on safe sleep. But our conversation today is on what happens outside of that birth episode and how do we address the leading causes of maternal mortality in the state of Colorado, which are actually related to mental health and substance use. And so with that, I'm going to pass it to my colleague, Lauren.
Thanks, Kylie. Yeah, so I'm going to take some time to walk through some data around the landscape of perinatal mental health and substance use. And as I go through it, there's a lot of data points in here, a lot of numbers, and I want us to remain grounded in our why, which is that every single one of these data points is a real person, a real story. It's someone who is loved, who has community, who has family. And I want us to really remember and honor that as we kind of go through a lot of data points. So first, starting with maternal mental health. Maternal mental health conditions are the most common complication of pregnancy and birth. They affect at least 20% of mothers in the US. And of those women, 75% of them remain untreated. And that really creates long-term ripple effects for both the mom, the infants, and their families. When we think about maternal mental health conditions, anxiety and depression are among the most common. 27% of women enter pregnancy with anxiety or depression. About a third develop symptoms during pregnancy, and 40% develop symptoms after birth. So, that's what Kylie mentioned during that postpartum period. And there's also a subset of women, 1 to 2 women per 1,000 live births, who experience psychosis, which is a really severe medical emergency that, left untreated, can really have disastrous outcomes for the mom, the baby, and their family. And then if we look at substance use, maternal substance use, reproductive age women are at a high risk for substance use disorder. And substance use in pregnancy is quite common, especially tobacco, alcohol, and marijuana. Those are the substances most frequently used, followed by cocaine and opioids. And oftentimes we see substance use disorders coexisting with perinatal mental health disorders, such as depression, anxiety, OCD, and PTSD. So it's important to note that pregnancy and substance use are not mutually exclusive, and anyone can experience both. There's been a lot of studies and surveys of pregnant women about the types of substances they're using. You can see some of these data points here below. A 2020 survey found that between 8% and 11% of pregnant women ages 18 plus had used illicit drugs, tobacco, or alcohol in the past month. And there's really this direct connection, right, between substance use and maternal mortality. Among the 22 states that looked at maternal mortality and had that pregnancy checkbox on death certificates, found pregnancy-associated mortality involving opioids increased from 4% to 10%. So seeing not only that connection, but also seeing the ways in which this is an issue that is worsening in some ways. If we look more specifically at Colorado, we have a maternal mortality review committee here that looks at statewide data to paint a better picture for us to understand what's really happening around maternal mortality in our state. And as we go into this data, it's important to recognize that there are disparities that we see with this data. Colorado, along with national data, we do really see disparities across race, with Black and Indigenous women experiencing maternal mortality at higher rates. And we also see disparities, particularly outside of urban areas, with rural and frontier counties seeing higher rates of maternal mortality as well. But when we look at the top 5 causes of pregnancy-associated mortality in Colorado from 2016 to 2020, suicide, unintentional overdose, obstetric complications, homicide, and motor vehicle collision are those top 5 causes. So we see there suicide and unintentional overdose as the top 2, and 50% of pregnancy-related deaths were related to mental health and substance use. That doesn't mean that people weren't experiencing mental health or substance use. 20% of pregnancy-related deaths that were not due to suicide or unintentional overdose were related to mental health and substance use. So even when people were experiencing death from obstetric complications or homicide, for example, they may also have experienced mental health or substance use issues. So it really shows how ubiquitous this is. And 70% of pregnancy-associated deaths from unintentional overdose occurred between 6 weeks and 1 year postpartum. So when you think about that standard postpartum care, right, that's that single 6-week postpartum visit, 70% of unintentional overdose deaths were happening after the visits were complete. And that's really where those gaps are happening. I just want to quickly touch on intimate partner violence. This is an issue that CPCQC has been looking a lot more closely at. As we saw, homicide was one of the leading causes for pregnancy-associated death. Pregnant and postpartum women face double the homicide risk compared to non-pregnant women of reproductive age. And a study found that IPV affects approximately 1 in 4 women in Colorado, with that risk increasing for women who are pregnant postpartum. Ultimately, I just want to bring it back to the fact that this is a preventable issue. 89% of pregnancy-related deaths in Colorado were deemed preventable. That means there's a lot of opportunity to support communities and decrease maternal mortality rates. As a public health indicator, maternal mortality is often considered a metric of the overall health of a community. And as we've seen, suicide and unintended overdose are the leading causes of maternal mortality in Colorado. So there's a lot of opportunity here to really increase and support the public health of our community by focusing on this. I also just want to highlight some great Colorado-based data that we have. We partnered with the Center for Improving Value in Healthcare, or CIVIC, to look at 170,000 deliveries that occurred in Colorado between 2019 and 2023, which is about half of all of the births in the state. And it revealed a lot, particularly that we've made progress and that there are persistent gaps in mental health and postpartum care during the perinatal period. This data found that 1 in 3 Colorado births involved someone with a diagnosed mental health condition, most commonly depression or anxiety. And it found that 2 in 3 postpartum individuals with a mental health diagnosis did not receive any services during or after their pregnancy, with only 8% of those with a diagnosed mental health condition completing 5 or more mental health visits. So again, there is these big gaps, but there's also this big opportunity. And that's why, that's where Impact BH comes in. And I think now Kylie's going to go into that a bit more.
Thanks, Lauren. I appreciate it. So let's talk about the Impact BH program. Impact BH stands for Improving Perinatal Access, Coordination, and Treatment for Behavioral Health. It started about 5 years ago in partnership with the Colorado Behavioral Health Administration, in recognition that from pregnancy and the full postpartum period, and when I say postpartum, we're talking through a full 1 year postpartum, pregnant and postpartum people, we interact with a lot of different types of providers, right? Maybe we interact with an outpatient clinic that's providing some of our prenatal appointments. We interact, 96% of births in the state of Colorado happen at a hospital. So at least for 96% of births, somebody's interacting with a hospital L&D and or an emergency department. Then postpartum, maybe we're interacting with the healthcare system ourselves. And if not, we're probably taking our infant or infants to a pediatrician, or if you don't have a pediatrician nearby, a full scope family med provider. In addition, we know that many different community-based services exist. And so Impact BH really exists to kind of quote unquote connect the dots, right? Or as our partners at the BHA like to say, really strengthen the connective tissue between these different entities that are providing critical services and care to pregnant and postpartum people as well as infants during the perinatal period. For those of you who have interacted with Impact BH over the years, you may know that our footprint is primarily in the western part of the state and in rural communities. This was an intention set by the BHA several years ago in recognition that rural communities both experience higher rates of maternal mortality and morbidity alongside typically increased challenges accessing care. And we see that happening in real time, right? As L&D units are closing, as mental health centers are closing sometimes in rural parts of the state. There is also this recognition and belief that rural communities have the unique ability to really be creative and work alongside one another to strengthen systems of care. That said, Impact BH is not, we have worked sometimes with urban areas, right? Technically, Mount Mesa County is an urban county, but they do serve a lot of rural and frontier parts of the state. For those of you who may have interacted with Impact BH in the past, you may know that we tend to have three main core components of this work, although in my presentation, I'll highlight there are going to be some shifts for the next grant cycle. So Impact BH is a 12-month collective impact grant program. It really is focused on strengthening and integrating local perinatal behavioral health services. And so when I say behavioral health, that means both mental health and substance use services. Impact BH has always been focused on strengthening early detection and effective response to perinatal mental health and substance use needs by really strengthening the SBIRT practices, if you're familiar with SBIRT, screening, brief intervention, and referral to treatment, across clinical and community settings. This upcoming year, we're planning to pilot a learning collaborative model. And so we're going to talk about that a little bit today, about what that looks like. In addition, Impact BH provides perinatal navigation funding, right? We recognize that home-based services, community-based services are really vital, especially when you think about that data point about how we're most at risk for mental health and behavioral health complications from 6 weeks to 1 year postpartum, right? That's typically a period of time where somebody isn't going to see their delivering provider or their PCP themselves, right? And so community-based providers are really vital in checking in with folks postpartum and connecting them with resources. So there is a grant portion of this. And then as well, Impact BH has always been focused on strengthening continuums of care, right? We know that when we are all connected from hospital to outpatient clinic to community-based setting, we can better provide clinical services and care to the pregnant and postpartum mom as well as to the infant. So I'm going to dive into the learning collaboratives a little bit because I know this is different for this upcoming year. So like I noted, in the past, Impact BH, we've always been focused on providing training and technical assistance to both community-based organizations as well as outpatient clinics focused on identification and response to perinatal mental health and substance use complications. This upcoming year, we are planning to pilot a learning collaborative model. We're doing this for a few different reasons. One, we have heard from past community members and Impact BH partners that there's a desire for more structure around the way in which we are providing clinical care and content. The Learning Collaborative model also provides an opportunity for outpatient clinics and community-based organizations to learn alongside one another around what are those best practices for screening, brief intervention, and referral to treatment, and then in real time, work through what do those referral practices look like in your own community? Where are the gaps? What are the needs? In addition, like I noted, CPCQC, we work with 100% of Colorado's labor and delivery units to implement quality improvement programs. And we know that a quality improvement learning collaborative, it works. It is the best practice for promoting and supporting change when it comes to SBIRT rates. And so it's something we're excited to pilot in this next year. And so the way that the learning collaboratives will work is that the learning collaborative structure will offer training and technical assistance through the learning collaborative on a variety of perinatal behavioral health SBIRT topics. We are planning to address identification of perinatal mood, anxiety, and substance use disorders. We're planning to discuss and collectively work on brief intervention. How do you respond when somebody screens positive? Not just for anxiety or depression or substance use complications, but what if somebody endorses suicidal ideation? What do you do? How do you respond? How do you safety plan in that moment? What if somebody endorses intimate partner violence, right? And this is something we're consistently hearing from clinical and community partners, is that it's really hard to know how to safety plan and how to respond to more complex clinical presentations and challenges. And so we're planning to fold that into the learning collaborative model for this next year. The learning collaborative model will focus on increasing and strengthening referrals to local, statewide, and national resources to help maternal and infant dyads access appropriate support. And then as well, sustaining these expert practice and advancements through improved workflows, billing practices, and connection to statewide resources. So a few different notes as well about the learning collaborative model. One, we are in the process of co-developing this model right now. And so we'll be really looking to our incoming partners, as well as we are in conversation with our current and former Impact BH partners about what is the best way to implement this, right? We want to make sure that a learning collaborative model works best for the communities that we're partnering with. So I will kind of put out that flag. And then as well, we do anticipate piloting kind of those learning collaborative meetings with quality improvement coaching, right? So the access to training and technical assistance around what does it look like to actually implement these new expert processes or workflows within your own setting. Some benefits, again, of a learning collaborative model is that it will provide access to evidence-based clinical curriculum that will complement the clinical curriculum that we're providing to hospitals. And so something we've heard from current partners is that it can feel energizing to know that we'll be bringing the same clinical content that your L&D is getting access to, right? And that can help kind of across the continuum of care, folks having that same foundational understanding of what best practices are, and then we can work on referrals together. It allows for better incorporation of peer support and lived experience integration. And then as well, we'll be working to really facilitate connections to statewide programs and support. So if you all have heard about the Colorado Prosper Perinatal Psychiatric Consult Line, the Prenatal Plus program through HCPF to support enhanced billing, to Medicaid for prenatal postpartum services, CU Women's Behavioral Health, BASOs, and more. So for these learning collaboratives, we are in the process of co-developing them, and we know that we will be requiring that a primary local perinatal navigation provider is participating in this learning collaborative, as well as a primary local outpatient clinic provider. Impact BH has always been focused on connecting community-based organization and clinical partners. So please know that that will be required. We do know that. And then we are saying we are encouraging participation from several other entities. Public health, if your public health department isn't implementing community-based perinatal services. Emergency departments, we know, especially in rural parts of the state, that perinatal folks may show up to an ED that doesn't have a local labor and delivery unit, right? And so we are hoping to fold emergency departments more into the work that we do. Hospital labor and delivery units, local home birth services, local certified community behavioral health center clinics, and more. So we are really encouraging our applicants to really pull together that continuum of care and collectively tell us how we can best support you all, and for you all to tell us who needs to be at the table to really allow this grant program and learning collaborative program to be the most effective in your setting. A little bit about data. Data collection is required through this program. We do anticipate primarily trying to collect data from that primary perinatal navigation provider, as well as from the primary outpatient clinic or clinics. And we're really looking at how can we collectively work together to increase referrals for perinatal clients who screen positive for mental health and or substance use needs. So that means we're looking at how can we better identify, so increase screening rates, and then for screens that are positive, making referrals. We often hear, and we know that a lot of times, sometimes it can be hard to screen if you don't know where to refer. And so that's really what we're targeting through this program. Our goal is to have a data collection plan that is as low burden as possible. Again, we will be bringing our incoming partners into the process to really finalize what the data collection plan will look like for this next grant cycle. But please know data collection is part of this program. And then the navigation funding, which I know is a really meaningful part of this program as well. We are able to provide communities with responsive funding to community-based organizations or organizations providing perinatal navigation services to enhance their services. This type of funding, it looks different in every single community. And again, we really look to each community to tell us how this funding can be most effective and efficient in your setting. Organizations in the past have used this funding to expand local perinatal navigation services, to launch new support groups, to train community members to become perinatal peers. Folks have also used this training to send local therapists to additional training to be able to, excuse me, better support the perinatal population. There are some restrictions on this funding because it does have some ties to federal funding. We really can't fund social determinants of health needs, travel, alcohol, food is really tricky. But typically we're able to fund staff time, staff resources to be able to implement these enhanced services. And then as well, right, for those of you all who have been familiar with Impact BH in the past, you may have heard us talk about this concept of a perinatal continuum of care working group. This is something that former Impact BH partners have decided to start themselves in recognition that in order to do this work well, former Impact BH partners felt like they really needed to bring themselves all together across the continuum of care into a working group. The way that this has looked in the past is that communities have either chosen to launch their own perinatal continuum of care working group. They choose the cadence at which they meet. They identify who needs to be at the table, and CPCQC in the past has just provided encouragement and support, as well as checking in to make sure those groups had access to the resources that they needed. Some communities, particularly this year, the communities we're working with are almost all deciding to incorporate the contents of a perinatal continuum of care working group into an existing working group meeting, right? In recognition that your community may already have a parallel working group and we don't want you to have to duplicate services. The big caveat I will share is that in this upcoming grant cycle, we will really be working with our incoming communities to determine, do incoming communities want to start their own perinatal continuum of care working groups, or do these learning collaboratives actually become the equivalent of that perinatal continuum of care working group? So I'll just put a flag that we don't have a requirement right now for this upcoming year that you launch a new working group. But I will say we will be in conversation with our incoming partners about, do they want to have a learning collaborative meeting every other month and then a perinatal continuum of care working group every other month? So this will be something that we will evolve and adapt in partnership with our incoming partners. All right, I'm going to pass it to Casey, who's going to talk a little bit about the expansion process, and then we want to open it up to questions.
Thanks, Kylie. Home stretch, everybody. All right, so our priority for future impact partners are those that are in rural or frontier communities in Colorado. HICPUF has a resource on their website to determine if you are in a rural or frontier community, if you need that. Priority is also given to those that have previously not participated in Impact BH. Submission of your EOI and the clinical and community ability to participate in a learning collaborative and a coaching call. We would like support from the birthing hospital and that they are participating in one of our quality improvement programs.
And I'll just add here too, really quickly, right, like I noted, we work with every single labor and delivery unit in the state of Colorado. You may live in a county or community that does not have a hospital with an L&D. That is okay. You are still eligible to apply to Impact BH. If that is the case, we encourage you to connect with the birthing hospitals in adjacent counties or county where perinatal women typically deliver. Connect with them, learn what hospital quality improvement program they are participating in. And we have had some success in the past with communities really working across county lines to implement Impact BH. I will also say really quickly here, we've noted, we have 2 of our 4 programs do have more explicit ties to perinatal behavioral health. That's our Turning the Tide program and our Spark program. That said, if your closest birthing hospital is not participating in one of those programs, we still encourage you to apply. So that is do not apply because of that.
Thanks, Kylie. So we receive funding from the Behavioral Health Administration at Colorado. They are pass-through funds from SAMHSA, and we are in our 5th year of receiving funding from the BHA. We are in the process of reprocuring a 5-year contract with the BHA, and that would fund this grant cycle. There is a chance that we are not able to reprocure the BHA funding. If that happens, there will be no grant awards. However, we are in the process of applying and we've been strong partners with the BHA. All grant-funded activities do have to comply with OMB guidelines since this is federal funding. So that's really what Kylie was talking about, the social determinants of health. We cannot fund direct client assistance. We cannot fund, bus passes, even though they're so necessary, but we can fund staff time and direct services related to this project. Um, and as Kylie mentioned, we're in the process of co-developing the pilot for the learning collaboratives. And those are ever evolving, and we are hoping that our future impact partners will have the ability to help inform us as we are developing the learning collaboratives. And so the structures, requirements, and data collection are still in the process for FY27. And when I'm saying FY27, I mean July 1st. So we do have another set of office hours on the 26th. It will be the same content and slide deck. You're of course welcome to come, but please, manage your time. We are taking questions both in this session, and you are welcome to email Kylie. She put her email on here, and we are posting an FAQ as questions come in, and we're updating it every Friday. So our expression of interest is due Friday, March 6th by 5 p.m., preferably in a PDF to Kylie. And for those that, fit the requirements and make sense in the impact model, will be invited to participate in the request for proposals process. This is where we'll be doing the budget development and supporting you all through the scope of work processes. We anticipate the RFP process will happen in April, and we are very hopeful that contracting will start in May. That being said, we are hoping that a new cohort starts on July 1st, but as I said, this is federal funding and there is sometimes delays in their contracting process.
Thanks, Casey. A few additional notes. So the EOI process is required. That is step one. From the EOIs, we anticipate selecting 3 to 5 communities to then be part of kind of our incoming cohort for Impact BH. And the RFP is just to procure who within those communities receives the federal funds. Because they are federal funds, we do need to have a specific RFP process that is associated with the grant funding. Okay. I'm sure you all have lots of questions. That is our slide deck. You will have access to the slide deck afterwards. I'm going to go ahead and stop sharing my screen so I can see the chat, and we invite you to either drop questions in the chat or come off mute and tell us what we can better explain. I know that was a lot of content in a short period of time.
I'll start. Hi, Kylie. I have an easy question and then like many sticky notes with some harder ones, but I'll start with the easy one. We have 2 hospitals where folks from our county deliver babies. Is there an easy way to find out which quality improvement program they are part of, or do we need to ask them?
Good question. We actually just confirmed this process with our QI team yesterday. So if you have contacts at your hospital, we encourage you to ask your hospital, right? That just helps continue to strengthen the connection between clinical and community setting and hospital. If you do not know, and this will also be in the Q&A document we'll post tomorrow, but you can email, it's called qi@cpcqc.org. I'm going to drop this in the chat. Thank you, Casey, I already did that. And that will go to an inbox that our QI team that focuses on hospital quality improvement they'll receive the email and they will respond to you.
Great. Okay. I'll let others go and maybe my questions will come up with them.
I'll go. Kylie, I think you kind of answered this. So myself and my counterpart, the director of our public health office in Custer County, is on this call, but we're very interested in this. However, we are one of those counties that does not have a hospital here. So Emily, I would actually come to you and say, okay, because we have families that go to Salida for labor and delivery, also St. Thomas More and Canyon City, so colleagues around that. But I guess that was my question, that we are still eligible to apply, because one of our biggest goals is, because we do have to, quote, travel down the hill, specific for labor and delivery and other things, we're trying to bring more resources here locally post delivery so that they're not constantly having to travel down the hill. That's the phrase we call it. So I guess my question is what kind of additional partnership would you recommend to us that like one, you changed the slide before I was able to write it down, but you said as far as two requirements, the primary local perinatal navigation provider, and then it was a primary outpatient clinic person. I couldn't write that down. So I just want to make sure that minimally we have some boxes that we can check, even though we don't have a hospital here. And we actually do have challenges with our local clinic. That's part of Heart of the Rockies. Families just being able to get in, which is true everywhere in a timely manner. So I guess that was kind of my question as far as making sure we have some of the minimum requirements here in Custer County.
Eileen, can
Yeah,
I jump in before you
please
answer her
do.
question? That I'm Charmaine Sandoval and I'm from Canyon City and representing maternal mental health on behalf of St. Thomas More. So Stacy, I'm happy to connect with you after this, but and you can go ahead and answer a question, Kylie, but I wanted to jump in there and say there is one here from St. Thomas More.
Charmaine, I'm glad you're here. This is what Impact BH is about, right? Trying to help bring us all together across the continuum of care. So I'll respond to a few different points in your question, Stacy. Let me know if I do not fully answer your question. So in terms of birthing hospital, right, you've got this connection with Charmaine now, but we do encourage you or other similar communities to connect with the hospitals where pregnant and postpartum women in your community deliver. That said, right, you do not necessarily need that hospital to be part of a learning collaborative, but we do really want to have that clinic that is providing prenatal and postpartum care. Sometimes we also have clinics that provide pediatric care, part of the learning collaborative. So I think a question for your team would be to Stacey, can people access prenatal or postpartum care locally, or do they also travel out of county for that?
It depends on the type of care. And I would
Yeah.
actually defer to Sarah. I don't know if she can answer that. It depends on the type of care. Some we do have locally and we're trying to bring more. And then others, yep, they have to go to Salida or Canyon City or even Pueblo.
Yeah. So what I would say is one, if you can get that local clinic to participate, that would be something I think we would look for. And then as well, something to note, the Impact BH has evolved over the years. When it first launched, it actually launched with more of a regional approach in recognition that we often, for those of us, including myself, who live in a rural part of the state, we cross county lines all the time to access care. And so something that is a possibility, for your community or for some other communities on this call is to potentially pull together maybe a joint application across county lines, right? You can loop in other communities into your application. In recognition that folks may not only receive care or deliver in Custer County. I will say, I think we are particularly interested in really supporting parts of the state that do not have robust access to prenatal and postpartum care. That is the crux of Impact BH. And so I would really kind of look to your team to figure out, what makes the most sense, with the understanding that our goal is we want to have the hospital where pregnant and postpartum women are delivering in connected to your work in some degree. They know that you're participating, working with nearby clinics or a clinic that is providing prenatal postpartum care. Does that answer your question?
Yes, it does. Thank you. And it's kind of my head was already there, to contact. I would obviously reach out to Emily and Charmaine. Thank you. Because we did back before COVID, I'm the director of the Early Childhood Council. We had hospital bags that we would take to Heart of the Rockies. We took them to Parkview and we took them to St. Thomas More. And it was, specific for families that were coming from Custer that delivered at those respective hospitals. So we've done that in the past. It kind of fell off because of COVID. But yes, so you did. Thank you very much.
Okay. What other questions?
I might have missed this, but Kylie, could you share how much funding we're looking at when we're looking at multi-agency? And it's kind of a two-part question, but um, if we're partnering with, let's say, Nurse Family Partnership and these other agencies, are we sharing that funding? And then is the person who applied the keeper of that funds? And do they distribute money to the partner agencies? So I'm sorry, it was a lot of questions all in one.
No, and Kylie and team jump in here. We anticipate $50,000 to $60,000 being awarded to each impact, um, partner. And with that, we do allow a 15% indirect as well. Um, Kylie, what we have done previously is one entity is awarded the funding. And yes, you might call that a fiscal sponsor. If you are wanting to fund multiple entities in one application, we would want one organization to be receiving the funding.
And to clarify really quickly on what Casey said, when she says 50 to 60,000, that's kind of per impact BH community per region. So if you had 3 different community-based organizations all applying, it would still be that same amount. And Charmaine, to your question too, right? That's why the next step of the process is an RFP to actually procure who in each Impact BH community will receive that funding. We have found in the past that sometimes communities have found that it's best for maybe a larger entity to receive the funding because they may have more structures in place to do some of the reporting and data collection, but then they make sure that the right entities receive funding. So we do have some flexibility, but there is an RFP process, and there is data collection and reporting associated with whoever receives that funding.
Yeah,
Thank
and
you.
I'll just add real quick, it is a reimbursement type grant. We are not able to prepay for the work. So we would have monthly invoices that we would reimburse for services provided.
All right, I have a question about the Learning Collaborative and the PCOC. I think you kind of answered it, and maybe it's very up in the air that they can be the same, they can be different. My concern is so our outpatient clinics are wonderful and I think would be really supportive of this and are already doing some of it. I'm very concerned about finding a physician who has time during their day once a month. I could for sure get someone from the birthing center. We have a really great pelvic floor physical therapy program that also sees women in their home. But to have a doctor, I think I'm going to have to make a really strong case to them. So I guess my question is, do we know the time frames of those? Because I think they'll say, well, what time of day are you expecting me to be there? Can that be flexible? Yeah, that's kind of where my biggest concern lies.
Very valid concern. So as a reminder, the goal with the Learning Collaborative is delivery of clinical content, right? We want to make sure that participating clinics have access to the best practices related to perinatal mental health and substance use identification and response. We will be working with our incoming partners to determine what is the cadence for those learning collaboratives, right? If a once a month cohort meeting for 12 months is too much for clinics, is every other month, right? So essentially 6 meetings over the course of 12 months. Is that in range for the clinics? That's something that we'll work together on. And we are planning to offer quality improvement coaching as well to clinical and community partners. And that coaching would then say, right, connect the clinic with somebody who can work very specifically with them on what are the barriers in their own setting and how can they address those barriers. And those meetings would be kind of as needed, like as requested by the clinic. that time would be more responsive and flexible. It's challenging, right? Clinics are really busy. And we do find that Impact BH is best implemented when you have a clinic at the table that is ready and that is able to say, we'll do this 12-month sprint, right? It's a short grant program. So it's a little bit of a both and, but we're also really receptive to feedback from incoming partners about what will work best. In the current model, clinics do already meet with our technical assistance partner at least once a month.
And does it need to be a physician from the clinic, or if there's a champion nurse, does that work?
We are still finalizing that, but at least in our hospital setting, it does not have to be a physician. It could be a nurse champion. And so I definitely think there's a path to it being a nurse champion through Impact BH as well.
Okay, and so for the EOI, since the PCOC and the Learning Collaborative, we're kind of like figuring out what that looks like. Can we just go ahead and say PCOC / Learning Collaborative, we want to do this, we're going to have the right people there, and we just don't know exactly what that looks like?
Absolutely.
Okay.
Absolutely. You do not have to have that all spelled out by March 6th. Really,
Okay.
what we're looking for with the EOI is, are you having conversations across the continuum of care? And is there buy-in across the continuum of care, especially from community-based services and clinic?
Okay. All right. Great. That's really helpful.
What other questions?
I have another one. So you talk about the navigation part of the funding and enhancing some programs that already might be in existence. By the end of the EOI in March 6th, do we need to know exactly what that enhancement looks like? Or can we say, oh, we know we have this home visit program or this support group, and there's room for improvement and more collaboration. And can you help us figure out what that might look like?
Yes.
Okay.
I will drop the EOI resource in the chat right now. I'm just going to scroll to the right page. So if you go to page 12, it includes the narrative questions for the expression of interest. And I believe there's one question, an open-ended question about how you would potentially leverage the perinatal navigation funds. But we do not need a budget. We do not need a specific plan.
Great.
At this point. Any other questions? Okay. Well, thank you all for taking the time out of your days to join us. We really appreciate it. Casey just dropped my email address in the chat. As Casey outlined earlier today, we will continue to receive questions over email. Our goal is to post an updated FAQ document every Friday with responses to questions we have received, as well as other frequently asked questions. And then again, we will have another office hour in 2 weeks that will include another opportunity to ask live questions. To Clea's question in the chat, yes, we have recorded this. We will post it on our website, hopefully tomorrow. Thank you all for joining.
Thank you.
Thank you.